And this is our website. If you haven't been there, please do it. And here we have the program. Our program is composed by 3 modules. So in the first module, we have pediatric neuroradiology tumors, so pediatric brain tumors. Module 2, we have adult brain tumors. And module 3 is a multidisciplinary module in which not only neuroradiologists will give lectures, but oncologists, radiation oncologists, neurosurgeons, pediatric neuroradiologists as well, and pediatric neurologists. We have a free session with webinars. So this is our first webinar that was undertaken 1 month ago, and today's webinar is going to be online soon. And if you go to courses, and if you click, for example, in the module, in the pediatric brain tumors module, you will see our lectures. And below the lectures, you will have access to several brain tumor cases. For example, this is one case of a medulloblastoma. It's a Wnt subtype. It's a male patient, 7-year-old. And if you click on the link, you will have access to all the images. This is a PACS kind of presentation. So you will have all the complete tumors, the complete set of images, which you can review and appreciate at home. So because of the problems with the connections, I would like to introduce Dr. Aashim Bhatia. Dr. Aashim is a very good friend, and I would like to thank him for the attention and for the time, for being here with us today. Dr. Aashim is a pediatric neuroradiologist, and he's an amazing person. He's an amazing teacher. He's a very knowledgeable person, and he works at the Children's Hospital of Pittsburgh. And it's an honor for us to have you here, Aashim. And the screen is yours. Thank you very much for being here with us today.
Thank you, Fabricio. Appreciate it. Just trying to make sure I get to the right. So everything's working. Does the PowerPoint slide show up and audio sounds good?
It's excellent. Thank you very much. It's I
All
can
right,
hear you
awesome.
well, and the slide is perfect. Thank you very much.
All right, thanks Fabricio, thanks Diego and Wilhelm for putting this course together and having me for the live session. It's truly a pleasure, especially following Dr. Pate with a great session last month. So I'll be discussing imaging of pediatric supratentorial brain tumors, and hopefully in the future we'll be able to be in person. I really hope everyone's doing well. I know it's tough times, but these live sessions at least bring us together for a short time to discuss important topics like this, like pediatric brain tumors. And so if you have any questions, I'm happy to answer them at the end. But before I start the presentation, this week we lost a true pioneer in the field of pediatric neuroradiology. Dr. Zimmerman passed away. He was a true leader in the field of pediatric neuroradiology, a mentor for many, including myself, where I did fellowship at the Children's Hospital of Philadelphia. And his contributions to the field are endless. And this is just one example. In the early days of MRI in the 1980s, he actually published on the early imaging characteristics of calcified intracranial lesions. So just one small example of his contribution to the field. And we'll just take a few seconds and I'll start the presentation. All right, these are my disclosures for the presentation. Just take a quick read through. I'm not going to read them. Personal disclosure, I'm a consultant from Group. And so the outline will go into the World Health Organization classification 2021, 2016, kind of show the transition of what's happening. We'll discuss a diverse group of tumors, a lot of diversity in supratentorial brain tumors, but I'll try to focus on the most common ones. There is a lot of variability, but the way I try to approach it is, if you were to enter a tumor board, what are the most common brain tumors that you're going to see? Those are the ones I'm going to try to focus on. But at the same time, there will be a few tumors which you might not have heard of. That's okay. That kind of pertains to the new classification and give you a preview of what to come. And so I want to dive deep into all the tumors. Obviously, it's a short time to discuss a large diversity of tumors. So for example, Fabricio is going to do a great presentation on supratentorial intraventricular tumors. So I'm not going to do too much on intraventricular, and Dr. Pate is going to go into embryonal tumors. So I'm just going to touch up on some of the embryonal tumors. And this slide, basically, I'm trying to show is based on age, the more common tumors might vary. So 0 to 4 years of age, embryonal tumors are the most common. 15 to 19 years of age, you don't even see embryonal tumors in the most common tumor groups, right? So this is something to keep in mind when you're putting a differential together. Keep in mind the age that you're dealing with. What's the patient's age? That will help you just in putting together, at least thinking about what the differential should be. And so for supratentorial pediatric brain tumors, some literature varies, but for the most part, in the 0 to 14 years of age group, 20% are supratentorial, might be a little bit more than that. In infants, it's about 30%. And they're a diverse group of tumors. There's low-grade, high-grade, embryonal, and we'll get into all those. And so this is the slide I've had for quite a while now. New, who 2016? Well, it's now 2021, so it's not, 2016 is not really new. So you cross that out, now it's new, World Health Organization 2021. And I'll go into some of those details, but for 2016, what is important is that there was for the first time, there was a molecular inclusion of the categorization of these brain tumors. So this is a big breakthrough in understanding these brain tumors, and that's why you'll see more frequent updates. There we go, slight freeze in the slide. So in 1979 was actually the first time the World Health Organization published the tumor classification, or central nervous system tumor classification. And there was more updates. So there's one in 93, the second edition, there was one in 2000, 2007. So you saw more frequent updates between the third and fourth edition, and then there was a big gap. So between 2007 and 2016, there was just an update. 2016 was an update to the fourth edition, and it wasn't actually a whole new edition. So in 2021, in a few months, we will be seeing the fifth edition of the World Health Organization classification. And going forward, you're going to see more frequent updates. So every 4 to 5 years, we're going to be getting new updates, a complete new edition. So in 2026, maybe it's probably going to be the sixth edition. And this is important for us to stay up to date on what's going on. What are the changes happening? I'm not going to go into C-Impact now, but that's a group you should follow because they're part of the World Health Organization. They're the pathologists and oncologists and the clinicians that are driving these changes, and they give frequent updates in between these large updates. Also, when you go to tumor board, it's important to keep in mind how this World Health Organization classification actually works. So you have layer 1, which is the integrated diagnosis of layers 2 to 4. Layers 2 and 3 are based on the histology. Layer 4 is based on the molecular information. And the molecular information is one of the big drivers currently of the final diagnosis. So when you go to tumor board, this is kind of what you're dealing with. You're getting the histology, you're getting some of the molecular characteristics from the pathology, and they're giving you a final diagnosis. And this is ever expanding. So as we speak, there's probably new molecular information coming out. And here are some of the common mutations in low-grade gliomas. You deal with BRAF mutations. We'll go into that briefly. High-grade gliomas, you go into histone mutations. We'll go into that briefly. And so this is the diversity of tumors we're talking about today. So in high-grade gliomas, the histone mutations are very important, especially in diffuse midline gliomas that we'll discuss shortly. Approximately 50% of pediatric high-grade gliomas harbor mutations involving histone protein complex variants. So that's a large percentage. So I think it's important to know what histones are then. What are they? It kind of reminds me of cell biology when you go back and you would study the DNA and it wraps around stuff, and there's a protein component of the chromatin that DNA wraps around. That's what the histones are. And they act as epigenetic regulators that control gene expression. So that's important. When you have a mutation in these epigenetic regulators, you can see how that can lead to tumor genesis. And so let's go into these diffuse astrocytic and oligodendroglial tumors. So in 2021, there's going to be the group of diffuse or pediatric type diffuse high-grade gliomas. There's also going to be pediatric type diffuse low-grade gliomas, a group of those. There's also going to be adult type diffuse gliomas. I'm not going into adults. We'll discuss low-grade shortly. But for pediatric type diffuse high-grade gliomas, there's going to be a diffuse midline glioma H3K27 altered. That's going to be one type. Diffuse hemispheric glioma H3G34 mutant, that's another one. There's going to be diffuse pediatric type high-grade glioma H3 wild type and IDH wild type. And there's also going to be an infant type hemispheric glioma. So let's talk about the diffuse midline glioma H3K27M mutant. They are tumors centered not only in the pons, thalamus, and spinal cord, but also third ventricle, hypothalamus, pineal region, and cerebellum. The most important subtypes to think about right now are the H3.3 and H3.1. The H3.1 subtype is only in the pons, so I'm not discussing that one in detail. The 3.3 subtype is located in the pons, thalamus, and spinal cord. And so the way I remember it is 3.1 is in one location, pons, 3.3, 3 locations. Also, the G34 mutant diffuse glioma we'll discuss is basically located in the cortex of cerebral hemispheres. And so why are these subtypes important? Why do we have to know them? Because they behave differently, they act differently, and thus they might require different treatments. So that's important to remember. They might behave differently, and the treatment will be based on that. For example, the K27M mutation H3.3 did not respond clinically to radiotherapy as well and relapsed significantly earlier and exhibited more metastatic disease than the 3.1 subtype. So there you can see an example of why it's important. And here are some imaging examples. So here's a diffuse midline glioma H3G34 mutant in an 11-year-old, where you have bilateral diffuse infiltrated tumors within the thalami, T2 hyperintense, flare hyperintense, no significant enhancements, and no reduced diffusion. So let's go through the 3 cases I have, and I'll explain the importance of this. Here's another infiltrative tumor, now unilateral in a different patient, right thalamus. Centrally has some reduced diffusion and centrally some enhancements, and maybe in the periphery medially there's some enhancement. So this looks different than the other tumor. This tumor enhances, the other tumor didn't. This one had reduced diffusion. Here's another example. This is a different patient. Now this tumor is actually cystic. So in the right thalamus, in the region of the right thalamus, there's a cystic mass, has peripheral enhancement, but also look at the diffuse metastatic disease throughout the spine. All this metastatic disease extending to the caudal nervus, the distal thecal sac. So now you're seeing 3 different examples of a diffuse midline glioma H3G34 mutants. And that gets me to this slide, where a nice study that looked at the imaging characteristics of these tumors. It really does nothing to differentiate the mutant from the wild type, but what's important is that there's a lot of variability in how these tumors can present, a lot of different imaging characteristics, which I just showed 3 examples of. And so the H3.3G34 mutant will be another addition to 2021. It's going to involve the cerebral hemispheres. These are tumors that involve the cerebral hemispheres. Will have a poor outcome similar to the H3G34 mutant diffuse midline glioma. At least that's part of what the literature shows. I think more studies will show how this tumor behaves and responds to treatment compared to the diffuse midline glioma H3G34 mutants. And so now let's talk briefly about the pediatric type diffuse low-grade gliomas. So we talked about the high-grade gliomas. There's going to be a diffuse astrocytoma, MIB or MIB-L1 altered. There's going to be an angiocentric glioma. There's a plenty tumor, which we'll go into. So actually, I'll show imaging of the angiocentric glioma and the plenty tumor. Diffuse low-grade glioma, MAC kinase pathway altered. That's another one that will be in the low-grade glioma. So here's an example of an angiocentric glioma, showing for the most part a pretty well-defined T2 hyperintense mass, maybe minimal enhancements. Tractography shows some displaced cortical spinal fibers around the tumor. I think as more literature comes out, we'll get a better feel for the imaging characteristics of this tumor. Here's some other examples. So in the right frontal lobe, this tumor, for the most part, is well-defined medially, but if you look, certain components of it have an ill-defined border. It has enhancements. This is right in the subcortical white matter, so it kind of infiltrates into the cortex. So it has an infiltrative component, also well-defined in this case, partially. This is the same patient. So once again, those laterally, there's actually some ill-defined components of this mass. On this slice, looks more well-defined. Flare hyperintense. Nothing specific to say this is angiocentric glioma, but these are examples of it. This is a different patient with an angiocentric glioma. Again, near the cortex. This is actually in the cortex with some cortical T2 hyperintensity, no significant enhancements. So let's look at other astrocytic tumors. One will be a pilocytic astrocytoma we're all familiar with. Cerebellum is the most common site, and nearly half are supratentorial. So in low-grade gliomas, the MAP kinase pathway includes 2 parallel cascades. One involves the BRAF, as you can see here, BRAF. So mutations in BRAF can often lead to excessive cell growth and tumorigenesis. That's why when you go to tumor boards, there's always discussion, what is the BRAF molecular show? And so the BRAF fusion is in a majority of pilocytic astrocytomas and has overall a good prognosis. While the BRAF V600E point mutation is seen in other tumors, including a small percentage of pilocytic astrocytomas. So if you have a PA with the BRAF V600E, it actually probably has more of a or worse outcome compared to the BRAF mutation. So that's why it's important to know these molecular characteristics. I know we're supratentorial, but I just want to show a classic example. So this is what you're used to seeing for your pilocytics. You got the cystic mass with an enhancing mural nodule.
Jim, sorry to disturb you. Can you hear me?
Yeah, I can hear.
Sorry, you know, Aashim, it seems that there is, the marker is on in your screen, in your slides.
Oh, yes. I thought someone else was doing that. Sorry about that. I didn't do that.
Well, I don't know.
I don't know how to clear it. Let me try. Yeah, I thought someone else was accidentally putting it on the screen, but let me see if I can clear it real quick.
Sorry to disturb you.
Oh, no, thanks. I was wondering, should I pause and see? I see an annotation tool here that says, oh, maybe eraser. Oh, there we go.
Because most of the slides were fine, but sometimes, okay. Sorry to disturb you.
Oh, yeah,
Please,
no problem.
Please continue.
Let's make sure there's no more annotation. Okay. So we talked about the pilocytic astrocytomas. When you talk about supratentorial, one of the more common one is your supracellular chiasmatic optic pathway gliomas. And you can see in this case, this patient has a pilocytic astrocytoma that's mostly enhancing, but has cystic components as well. This turns out to have the BRAF mutation, BRAF V600E. Here's a different patient. So there's another supracellular pilocytic astrocytoma, chiasmatic optic pathway mass. It has more solid components in this case compared to the other one, but this turned out to be a BRAF fusion. So imaging can't differentiate the fusion from the mutation. There's really nothing currently, but this study was interesting. It's I guess the first step. The ADC values are statistically lower in BRAF mutations compared to wild type. So it's not comparing fusion and mutations, but comparing to the wild type, the ADC values are lower in the BRAF mutation. So let's talk about neuronal and mixed neuronal glial tumors. So DNETs have very classic imaging findings. When you see this tumor, this is one of those tumors where you can be pretty confident that the diagnosis is DNET. So when you see that bubbly bunch of grapes appearance, it's going to be cortical for the most part, well demarcated. This is most commonly going to be a DNET. It's also a very useful sign as this hyperintense rim flare sign. So when you see this hyperintensity on the rim of it, bubbly grapes of appearance, this one has minimal or really no enhancement. DNET is top of your differential. Has another example, bubbly grapes of appearance on the T2 sequence, has that hyperintense rim flare sign. And on the inner table of the calvarium, you can actually see some scalloping or remodeling of the inner table. That's nothing specific to DNET. A PXA can also do that. Really, it's just any slow-growing, low-grade glioma that happens to be near the calvarium is going to cause that scalloping. But it does suggest that it is a low-grade tumor and not more of a high-grade tumor. Another example, DNET, T2 hypertense lesion. When you do see enhancement of these, this is the post-contrast sequence, you'll see that little nodular area of enhancement. That's what I typically see with these tumors. And here's again, the hyperintense rim flare sign, a nice imaging characteristic of a DNET. Another DNET, once again, nodular enhancement. That's typically what you're going to see. Look at that bunch of grapes. That's probably one of your best examples of a bunch of grapes appearance. Again, hyperintense rim flare sign. So let's go into non-NF1 risopathies quickly. So this is actually a study that I'm doing with the director of pediatric neuro-oncology here at the Children's Hospital of Pittsburgh. He's recruited multiple patients with non-NF1 risopathies. Some examples are like Noonan syndrome. And what is thought to what's thought about these patients. So let's put an NF1, they're predisposed to PAs and a lot of low-grade gliomas, right? With non-NF1 rhizopathies, we do know they're predisposed to tumors, but are they predisposed to CNS tumors? That's the question. It's not really clear. That's what the study is for. So this is just one example from the study. What we noticed is multiple patients, this is just one example, they have multiple tumors and a lot of them look like DNET. So here's left temporal lobe, kind of a bubbly appearance. Right cerebral hemisphere, another bubbly tumor. Not all of these tumors are biopsied, but a majority that are turn out to be DNETs. Minimal enhancement in this case. This is baseline imaging. At least for this case, let's just say this is baseline. And then 3 years later, you see this tumor's still there, that tumor's still there, obviously. But you start seeing is these little T2 hyperintense lesions developing. Another one in the right temporal lobe here. Maybe another lesion here. Near the dentate. And you start looking, here's a flare sequence. So here's the tumors that we've seen already. They start developing these additional flare hyperintense lesions throughout. And what we believe is these are multiple low-grade tumors. Probably a majority of them are going to be DNETs. And I see another marker coming up. That's not my marker, so I don't know where that came from, the yellow dot. But all these arrows are pointing to tumors. A lot of them are the ones I just demarcated, the large ones. But you see these smaller ones, we believe are these non-NF1 rhizopathy patients are predisposed to multiple tumors, most of them DNET. So it's kind of interesting. There's not a lot of literature on it. It should be published pretty soon. Septal DNET. You can also have septal DNET. So this is along the septum. They're T2 hyperintense. They're going to have hyperintense rim flare sign, like in this case. They also have a high frequency of mutations in the platelet-derived growth factor receptor A. And the methylation also suggests that these are separate molecular subtypes. Now I see a bunch of yellow dots. Sorry about that. It's not mine. But hopefully they don't interfere with any of the imaging. So ganglioma, the thing I like to think about gangliomas is that they are very similar in appearance to DNETs. I'll mention a few imaging characteristics that can help differentiate it. Calcification is one, it's more common in gangliomas. The enhancement in DNETs is more nodular. This is a ganglioma, see how much, there's more diffuse or more solid components. And they also have more cystic components compared to DNETs. But those are, a lot of times you'll put the two in the differential together, that's fine. Like in this case, ganglioma, you could easily put DNET into differential. Does have more enhancement, T2 hyperintense, has some flare hyperintensity. What about anaplastic ganglioma? Really, there's nothing definitive to say this is anaplastic, but it just looks more aggressive. Hyperdensity is representing some calcifications, susceptibility, very large, very heterogeneous appearing, some minimal enhancement, but look at the amount of mass effect. So just much more aggressive appearing, that's more likely going to be an anaplastic ganglioma. Again, another example. This study tried to describe some of the imaging characteristics, but really nothing specific, heterogeneous. That's nothing specific for anaplastic ganglioma, but it helps differentiate it from a low-grade ganglioma, right? Another anaplastic ganglioma, very heterogeneous, a lot of enhancement. This is causing a lot of vasogenic edema. So you can see in this case why this would be more likely anaplastic ganglioma. And so this is one tumor no one should get wrong in the diagnosis. If the patient presents with this tumor in a certain clinical setting, you should think about the desmoplastic infantile ganglioma or astrocytoma. These are going to be large at presentation. Look at the size of this tumor. It's going to be very cystic, and the solid components are going to be plaque-like or on the periphery. See how there's this peripheral enhancement along the large cystic component of the mass? So if you see a large hemispheric, predominantly cystic mass with peripheral solid components in a child that's less than 6 months of age presenting with seizures, your number 1, 2, 3 differentials are DIG. And most of the time, they're easy diagnosis. Here's one example where it wasn't so easy. So this patient, actually at 1 week of age, was imaged for an HIE concern. This was not picked up as a tumor. It was unclear what the signal was in the right cerebral hemisphere. And then just a few months later, this patient is now 8 months old. Look how much larger this tumor is compared to at 1 week of age. I mean, it doesn't even look like the same patient, but it looks like a dig. Large mass, almost taking up the whole right cerebral hemisphere, cystic, has those solid components. The solid components are once again a peripheral plaque-like. This one actually has reduced diffusion. So look at here. This is DWI and ADC map. This actually was a dig with anaplastic features. But an example of how you can see this tumor progress so quickly. That turned into that somehow. Kind of scary. A new addition to 2021 World Health Organization classification, plenty tumors. So polymorphous low-grade neuroepithelial tumor of the young. This will be a pediatric type diffuse low-grade glioma, strong association with epilepsy. There might be some imaging characteristics that can help you. So here, the salt and pepper sign on T2 weighted imaging. Kind of looks like a salt and pepper. This is obviously like a right temporal lobe tumor. Flare. Some annotations coming out, those aren't mine. But once again, this, you kind of have a hyperintense rim like Adena would, but that salt and pepper sign is interesting for a plenty tumor. Let me go ahead and just clear these annotations real quick. It's probably someone accidentally has their pen on. Or maybe someone trying to point out a new finding on one of these cases. All right, I think that's good. All right, here's another example of a plenty tumor. Once again, it kind of has, this is flared, but you kind of imagine it has like a salt and pepper type of appearance. For the most part, well demarcated and significant calcification. So when you see these dense calcifications associated with a tumor like this on MR, plenty should be behind a differential. I think obviously more studies are needed to really characterize these tumors, but this is a good first start of how these tumors will probably look. Embryonal tumors, I'm not going to dive too deep into this, but embryonal tumor with multi-layered rosettes, formerly etanter. Once again, imaging studies are going to be needed to really classify these imaging a little more clearly. But right now, a mass with poor enhancement, significant mass effect, not much surrounding vasogenic edema is going to be a good descriptor. Here's an example, not much enhancement, large mass. Look at the mass effect, there's midline shift, heterogeneous. This is a good example of an embryonal tumor with multi-layered rosettes. Here's another example, large mass. Or actually going back one, not much vasogenic edema, another important imaging characteristic or likely important. Here's another example, large mass, not much vasogenic edema. This one actually probably has some reduced diffusion in it. Maybe minimal enhancements, but there was some T1 shortening there. Anyways, seeing the mass effect, again, no vasogenia. This is a good example of embryonal tumor with multi-layered rosettes. So let's go into ependymal tumors. This is going to be another change in 2021. Ependymoma is the third most common tumor in children. We see it quite a bit. This is what we're used to seeing. We're discussing supratentorial, but what we're classically taught, poster fossa, tumor that extends through the foramen magendi, Luschka, through the foramen magnum. That's your classic ependymoma. But things are changing. So now we're going to have infratentorial tumors. We're going to have supratentorial ependymomas. So there's going to be two different classifications, really. For supratentorial, one of the molecular characteristics of one of the subtypes is the YAP1. And initially it was supposed to be REL-A, but it's actually going to be C11 or F95 fusion. So that's, in replacement of REL-A, you're going to have this fusion. But this fusion is actually predominantly with REL-A. So this C11 or F95 fusion, predominantly with REL-A, but it also could be with some other molecular fusion anomalies. And here's an example. So here's a REL-A or the C11-4F95 positive ependymoma, and nothing specific to say that this is not a YAP1, but you have the heterogeneous enhancement, you have a flare-up intense lesion. As I compared to YAP1, the YAP1 tumors are often large, periventricular with prominent cyst formation. They have a favorable prognosis compared to REL-A fusion, but more imaging will be, again, needed to differentiate. So you can see one of the challenges with these new WHO updates is when they come out in imaging, you kind of have to scramble to see what imaging are we familiar with these type of tumors. For example, PNETs, we don't use PNETs anymore. We have large literature on imaging findings of PNETs, but PNETs are a diverse group of tumors now, so you can't really use that literature. You kind of have to, this shows the importance of staying up to date on the C-Impact now and the World Health Organization updates, working with the pathologists so you can start developing these imaging findings that will be hopefully more classic for ependymomas or any other tumor. There's also going to be a spinal ependymoma, in addition to supratentorial, infratentorial, there'll be spinal. There'll be a myxopapillary ependymoma. There's also going to be a subependymoma. So a lot of changes coming. And I'll briefly go into choroid plexus tumor. We're not going to spend a lot of time, but there are some interesting imaging findings in choroid plexus tumors because they have very classic imaging findings. You get this frond-like diffuse enhancement. This is centered with the third ventricle extending into the foramen Monroe into the lateral ventricles. But when you have that frond-like enhancement, that diffuse enhancement, and that imaging, that's choroid plexus papilloma until proven otherwise. How do you differentiate it from choroid plexus carcinoma? Sometimes it's not easy, but if you have parenchymal invasion, all this vasogenic edema, it's more heterogeneous. Not really very much more heterogeneous, but that parenchymal invasion is a clue. That's a choroid plexus carcinoma. I'm not going to show a lot of spectroscopy, obviously, so this is just one example. One of the cases where spectroscopy can help you. In a choroid plexus papilloma, the myoinositol to choline ratio is elevated versus carcinoma, where choline to myoinositol ratio is elevated. So spectroscopy can help you in this case, right? So here's a sibling A presenting with P53 tumor suppressor gene mutation. Had this large ATRT. Sibling B presented with this enhancing lesion in the left lateral ventricle. Really nothing too concerning about that enhancing lesion. At the worst, it looks maybe like a choroid plexus papilloma. But spectroscopy was performed in this patient. If you look at it, the choline to myoinositol ratio is actually elevated. So here's a spectral profile. If you compare it to a choroid plexus papilloma, the myoinositol to choline should be elevated, but this is the opposite. This actually turned out to be a choroid plexus carcinoma, and the imaging tool that helped was spectroscopy. Nothing else on the conventional imaging was suggestive of a choroid plexus carcinoma. So here's a good example of how to use your advanced imaging. And really the future of radiology, pediatric neurology, we're going to be hearing about radiomics. I think it's going to be a big component of what we do. So what is radiomics? It basically involves conversion of images to higher dimensional data that can be visualized with the radiologist's eye. You're going to see a lot of imaging futures being discussed. So look at a lot of the papers, there's standardization of the nomenclature for radiomics. And I think in the future, radiomics will be the tool to help us, one of the tools to help us in differentiating subtypes of tumors. That's currently where the research is heading. So multiple papers on radiomics, not only helping in subtyping, but predicting prognosis, predicting tumor response to treatment. So a lot of interesting work being done in radiomics and how it relates to what we do. There's also a radiogenomics component and a lot of other work being done. But what I really believe, in addition to layers 1 to 4 that we discussed, I believe in the future we'll have a layer 5 with radiomics that can help contribute to our understanding of these tumors, and it'll hopefully help in a final diagnosis for these patients. So once again, disclosures for my presentation. Here's a quick announcement. I'm chair of the Education and Research Committee for the ASPNR. We have a great research grant coming up. The letter of intent opens March 1st. So Monday, the letter of intent opens. This is a $25,000 award for innovative research in pediatric neuroradiology. I hope everyone gets the opportunity to apply. If you know anyone that's looking for some research funding with COVID-19 environments, there's a lot of decrease in funding in places. This one is good to go. March 1st, Monday is opening up, and thanks to Group A for the support on this award. And also thank many people that have helped provide cases over time. I hope I've acknowledged everyone. Sometimes it's tough as the cases keep on flowing in. I try to keep track of everyone's cases and mention their names. So thank you again, Fabrizio, Diego, and William for the invitation. And looking forward to some more hot topic sessions.
All right. Thank you very much, Aashim, for the amazing lecture, a very interesting collection of cases. And thanks for presenting a very complex topic in a very intelligible way. And maybe we have time for one or two questions. I have one question that popped up in my cell phone. Just a second. The first question, if it's possible, Aashim.
Yeah, I have time.
Okay.
I'm not at work till 6 p.m.
How do you work image standardization to use quantitative features for radiomics? This is a question.
How do I use it currently? Was that the question, or how do we plan to use it?
Or I think he's asking if you are using how and
Oh,
if you
yeah.
are using, how would you do it?
Yeah, that's a good question. So I've been talking to people about that. How would you implement radiomics into your radiology reports? How would you implement it into tumor board sessions? Fantastic question. I don't think anyone really knows. Right now, my feeling is the imaging features that we discuss, like, I mean, they're not enhancements or those features, are different definitions that you use, like kurtosis and these other characteristics. I believe a component of that will have to be put into the radiology report, and a lot of this will be streamlined. So I think by the end of the work being done in radiomics, you'll kind of have a list of the most common or more likely diagnosis based on your pipeline that you use for radiomics. But at the same time, I think some of the radiomic features will have to be discussed in the radiology report to help explain why you think it's these top 3 tumors. That's the way I would plan to approach it, to try to implement the radiomic features directly in. I have a feeling that also it'll be so streamlined, you probably don't need to. You could probably just say radiomics suggests it's these top 3, and then you would look at the imaging yourself and hopefully agree with those differentials. But that's the biggest challenge right now, is how do you get from the research setting to implementing in the clinical setting? And everyone's approaching it probably slightly differently. I have my own mindset of how I would do it, but I'm still in the early stages of doing that. So I haven't actually implemented it personally.
Yeah, I like your concept of the 5th layer, because it gives us, it further increases our value in terms of treatment and evaluation. And I like your concept of us being one of the layers of the
Yeah, exactly. And
yeah,
like, it could become so streamlined that, like, you got to put benefit of what the radiologist is doing. So it's not just spitting out what the radiologist is showing. You still got to look at the conventional imaging. And if you really look at it more complex, what if you had tumors that were being imaged multinuclear? So you got sodium imaging, you got all these other imaging characteristics. You got maybe PET agents that might help characterize these tumors in the future. So there's always going to be a role for radiologists. There's only so much radiomics will be able to do. But when you start throwing in these other additional imaging biomarkers, that's really where the radiologists come into value. But obviously more work is needed before we get to that point. of using multinuclear and using PET agents, but that's the future, is putting all this together. And what I believe is, if a patient gets imaged at your institution with a new tumor, by the end of the day, you can predict most likely that subtype of tumor. You can predict the patient's likelihood of responding to the tumor. You can almost tell the oncologist what kind of treatment that patient should get.
Aashim, we have probably 3 more questions. Do you have time?
Oh, yeah.
Okay,
Definitely.
great. One of the questions that Dr. Ehans wrote on the chat box is similar to mine. When I had the same question while you were presenting. How would you distinguish CAPNON, which is those stimuli calcified lesions in the brain, like brainstorms, from plenty?
But what was the first one you said?
CAPNON, C-A-P-N-O-N.
Oh, that I would have to look that up. Unfortunately, I'm not.
I think
if you're just going off calcifications,
yeah, CAPNON mostly. CAPNON is pure calcification, and there's no significant brain changes surrounding, right? I think that's maybe the way to differentiate, because plenty has I've never heard of this entity before, but it seems that it looks like a DNET type. It looks like it's similar to a DNET as well, right?
Yeah, it's going to be in the likely mixed neural glial tumor classification with DNETs. I don't know exactly how. I haven't seen the full categorization of tumors. I've heard like pieces of what the 2021 is going to look like, but I think once we see the full chart of the breakdown, it's going to be a little more clear. But yeah, the plenty is actual. If you get the MR imaging, you're going to see a mass there. So
yes.
You said it looks like DNET. It has that salt and pepper appearance on T2, which is a little different than the DNET. I haven't seen that. I haven't seen enough plenties to say that for sure. So I think that's also.
I have I have a very interesting question here. Do you think diffusion could be a good tool for predicting treatment response in embryonal tumors?
Currently, a lot of work has been done in diffusion. Do I think that's by itself going to predict it? No, because several studies have looked at diffusion and predicting subtypes, and like there was one example for the BRAF versus wild type that helped differentiate just those. But once you get into tumors that all are likely to have reduced diffusion, like all of the embryonal tumors, and then you start trying to figure out which ones are going to be responsive or predicts prognosis, very unlikely. You would need other imaging biomarkers.
Wow, so many questions here. What protocol do you use for pediatric brain tumors, Aashim, in your institution?
Good question. I was going to put a slide in there, but it's a work in progress. I think the other thing is every institution does it slightly differently. So I've implemented a new protocol here that includes dynamic contrast enhancement, dynamic susceptibility contrast, so dynamic post-contrast imaging. You have your standard conventional imaging, right? You got your diffusion, T2, flare, pre-T1. You can have your SWI sequence. You're going to have a diffusion tensor imaging. That's in addition to your standard diffusion weighted imaging, but you could probably just get away with DTI only. The ASL we perform, and some of this might not provide clinical benefit immediately, but your dynamic perfusion imaging, that's something that I wouldn't say like you have to do it, but if you're looking for more advanced imaging tools in cases of residual or recurrent tumor, that perfusion imaging might help. I don't have enough experience yet to say this is a definitive that you need to use it, but that's the imaging protocol, and then you have your standard post-contrast imaging. But it's a little more complex than that, because if you have an optic pathway mass, that tumor protocol is going to be altered slightly. I will mention, for any new presentation of any tumor, you should run, after you run your brain imaging and you get your post-contrast brain imaging, you should run post-contrast spine imaging, which should include sagittal T2s or sagittal like BFFE or Fiesta sequences. That's actually what we run. And then sagittal post-contrast imaging of the spine. That at least is some screening for metastatic disease. And you can also run post-contrast T1 axial through the spine as well. So you got your tumor protocol. And in cases where there's residual, if you already know that this patient's been followed up for 2 to 3 years with no no signs of recurrence, like a low-grade pilocytic, you don't need to run all these advanced imaging, right? Oh, sorry, the other thing, spectroscopy. For all tumors, we run single voxel MR spectroscopy, and multi-voxel we only run in certain cases when needed. So going back to a patient that's had no residual tumor for a while, stable, we're just following it up every year. Those patients don't need that residual, or what some people might consider more advanced imaging protocol. In that case, much more simple. You have your standard conventional sequences, your post-contrast imaging, you should be done in about 30 to 40 minutes.
Okay, thank you very much, Aashim. Two last questions. What TE do you use for spectroscopy? And there's an interesting question here. And what do you recommend to differentiate focal cortical dysplasia from low-grade glioma?
Okay, so for spectroscopy, we use single voxel MR spectroscopy with LC model, 2x2. There's a voxel size. And yeah, so we use single voxel. Multi-voxel, like if there's a diffuse infiltrative tumor, occasionally we might put it in there, but for the most part, I think over 90% of our spectroscopy is single voxel. And then cortical dysplasia versus a low-grade glioma, really, I just look at the conventional imaging characteristics, and you could use spectroscopy in those cases, but the problem is probably in a single voxel, are you gonna get enough adequate coverage of that area to get a reliable metabolic profile? You could try it, but in the end, you're probably still just gonna stick to your conventional imaging characteristics. If there's significant mass effect, if there's growth over time, maybe a lot of cases when you're not sure, what do? We recommend a follow-up, right? If there's slight growth, then we're pretty sure that's a low-grade glioma versus some other pathologies. And that's because no one's gonna intervene on that low-grade glioma right away anyways. Most of the time when they're that small, there might be incidental findings. If they are symptomatic, you do, I guess, the spectroscopy and do a close interval follow-up would be my approach.
All right.
And obviously enhancement. If you had enhancement, then it's easy. Then you know it's low-grade glioma.
Exactly. Aashim, thank you very much for your kind attention. Thank you very much for your time, and for this wonderful lecture. It was amazing. I mean, it was an amazing experience for us. Thank you very much.
Thank you for having me, and I hope everyone's doing well.
Okay, thank you very much. And for the ones that are not registered yet to our course, today we are having a promotional code. If you go to our website today, it's going to only last for 24 hours. And you go there and type webinar promo, and the code is in the chat box. You have a 20% discount, and you're going to be able to see all the cases that we are posting out there. We are having new lectures every week, and new cases every week, and several cases that are pathology proven, molecular proven. And I hope you enjoy the webinar today. And we are looking forward to have you another webinar in the end of March this year. Thank you very much. Thank you very much, Aashim, once again, and thank you, Guilherme and Diego, for your presence. Thank you very much.